everybody, to today's community conversation on medical gaslighting. I am absolutely honored to have Dr. Nicole Rochester here as your speaker, and we'll have her give her introduction and get us started in just a second. My name is Dr. Melinda Stewart. I am going to be your moderator, and just want to welcome everyone to this conversation that is extremely important for things that we are seeing each and every day in our own lives as well as our medical experiences. So, Nicole, I'm going to jump right in and have you give a little bit about your background and then have us start with what do we mean by medical gaslighting? What is that?
Sure. Well, thank you, Melinda, and thank you all for being here. It's really an honor to have this conversation. I'm Nicole Rochester. I am a pediatrician by training, and I say once a pediatrician, always a pediatrician. However, I am not practicing clinical medicine. I left my clinical and academic career in 2017 to start my company, Your GPS Doc, after a caregiving journey with my late father. And that work has morphed from one-on-one advocacy work to doing coaching of physicians, other physicians who want to start health advocacy businesses, professional speaking, and healthcare consulting. I am also the proud mother of two young adult daughters. And I want to share that it is really my experiences with them that prompted my kind of foray into medical gaslighting and doing this talk. So they have been subjected to medical gaslighting on countless occasions, and it has significantly impacted both of them physically and emotionally. So maybe we'll talk more about that later. In terms of like what is gaslighting, I always like to provide a little bit of history that I learned when I started researching this topic regarding the term itself, gaslighting, before we get into medical gaslighting. So gaslighting itself, you may know, is the practice whereby a person in power uses manipulation to make another person doubt his or her own judgment or their sanity. And the origin comes from a movie that I have not seen. Maybe some of you have seen it, but it was released in 1944. The movie was called Gaslight. And in that movie, the main character was a newlywed, and she moved into her deceased aunt's home with her new husband. And the gas lights in the home would mysteriously turn on and off. And when she would ask her husband about it, he would basically lie and made her to believe that she was insane. Ultimately, she ended up being committed to a psychiatric hospital, and he basically took all of her money. So, and you may have seen it also in the realm of emotional abuse and narcissism, but really gaslighting is just this idea of manipulating someone in a way that literally makes them question their own reality. And it is a form of psychological abuse and emotional abuse. When we talk about medical gaslighting, it is a specific form of manipulation that occurs when healthcare providers make patients doubt their symptoms, their experiences, or their feelings.
So I have seen the movie with Angela
Oh.
Lansbury. So it is a very, very good book or a good movie if you're interested. And I think I love that you provide this original definition. And I think sadly, so many of us know it from our relationships, even with family members and unfortunately romantic relationships. And I think we've got some ideas of what it might sound like from that personal side, but how might this sound? What does medical gaslighting sound like? How do we know that that's what we're experiencing?
Yeah, thanks, Melinda. And that's important because just like with gaslighting in the context of romantic relationships or friendships or family, it's very subtle. And that's why it can be very difficult to recognize. And it's even more subtle sometimes in healthcare settings. And the other thing I want to add before we talk about what it looks like is that unlike in romantic relationships, just as an example, whereby the person committing the act is almost always doing this intentionally. In healthcare settings, this is not to dismiss the providers. It is often unintentional. And we'll talk a little bit more about why it happens. But medical gaslighting can look like dismissal, which can present so many ways. But many of us have probably had clients, and maybe you've experienced this yourselves, where they go to the physician, the nurse practitioner, the PA for a particular complaint or concern. and they're literally dismissed. Sometimes they are told things like this is all in your head, which would be like the extreme form of medical gaslighting. But sometimes it's just that their concerns aren't taken seriously. There are some times where their physical concerns are inappropriately attributed to underlying mental or emotional health conditions, particularly if they have an underlying psychological condition. So let's say they have anxiety, as an example, and they come in complaining of severe abdominal pain or headache. The provider might say, "Oh, you're just anxious," or "Oh, you just need, rest." And they will immediately, "Oh, you're just stressed out." And so, without even taking the time or the effort to appropriately evaluate the medical complaint, the provider may immediately ascribe it to an underlying emotional condition. Another thing that it can be is they may inappropriately ascribe it to underlying health conditions. And so if we talk to specifically women, but all obese individuals, you will hear this a lot. People who have obesity or people who are overweight, almost every complaint that they present with, they will tell you often is met with, you just need to lose weight. And that could be something like maybe knee or joint pain, where, okay, maybe there is a logical connection between joint pain and bearing excess weight, having some, increased pressure on the joints. But from headaches to, there have been patients with headaches, as an example, blamed it on the weight. They ended up having brain tumors or ended up having, pseudo tumor. So that's another way that it can manifest itself in a somewhat extreme form, but unfortunately, I've heard and talked to many people who have experienced this. Sometimes medical gaslighting can look like a refusal to perform a workup for a particular condition. And so not only are they blaming it on other things, but there are instances where the healthcare provider will literally refuse to draw labs or refuse to send them for radiologic testing. And in some cases, we've heard where the patient will say they were even kind of threatened with, well, if I mean, I don't think there's anything wrong, but if you want me to send this test, you're just going to get a big medical bill. So, kind of scaring them with this idea of possibly facing a medical bill as a way of convincing them that there's actually nothing wrong with them. And then sometimes they will just frankly say that they don't believe them. And that's more unusual. It's usually more of a dismissal or a questioning or a lack of care and attention to the person's complaints.
I think the fact that you mentioned that this is often unintentional is a little hard to stomach because some of these things, while they are microaggressions and they might be, paper cuts of comments, they can have real major impact. I know the working with the LGBTQIA population, this idea of everything relates to their hormones, or as you mentioned, being overweight, everything, oh, I'm not going to look at any of these things because of this. That I think so many would dismiss. And it just reminds me of how important having an advocate there to listen for this when we might not be seeing that as gaslighting. Because if you've listened as somebody who survived emotional abuse from a partner, it happened for years and I just dismissed it. I didn't think that that was gaslighting. So this really calls attention to the importance of having an advocate that is aware of these things, can listen for these comments being made, and then can help do that advocating and maybe take a more of assertive role of saying, no, wait, 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 no, we're going to do this, or here's where you need to push. So in, like you said, in a lot of relationships, it's intentional, but you mentioned it might not be intentional for the providers. Why might they be doing this? Why is this happening?
There are a lot of reasons. I'll start with the systemic factors. And so, as a physician, I am very aware of the system in which we practice. And again, this is not to excuse individual behavior, but as we all know, all of us advocates know that, and patients and families and healthcare providers, all of us agree, I think, that the system in which we provide healthcare is extremely broken depending on how you look at it. Systems function as they are designed. So it's broken, but it's actually functioning as it was designed. But having said that, there are so many barriers within the system itself that can make it easier for a healthcare provider to gaslight a patient, perhaps unintentionally. So one is time. So there's significant time barriers. A lot of times, the patients that report gaslighting are sometimes the patients that have complaints that don't necessarily fit in the perfect box, right? It's not the kind of thing where as soon as the patient says a thing, you're like, oh, I know what that is. And so these encounters require time. And when you have 7 or 9 or 10 minutes for each patient, when you are, falling behind, when you're looking at the angry patient sitting in your waiting room, it can be easy to have this kind of disconnect. And it's almost like a competing priority. You want in your heart, you want to provide the best care for the patient in front of you. And you recognize that you don't have unlimited amount of time. And in many cases, doctors and other healthcare professionals are compensated based on their productivity and literally like the numeric value. How many patients can you see in an hour? How many codes can you bill for? And so we create these systems where we have physicians and other healthcare providers literally making decisions between their own ability to provide for their families and for themselves and good patient care. And no one should ever be put in that situation. And so sometimes it's the time barriers and just the fact that the length of the average patient visit is almost never enough time, even for something simple, let alone time to really explore complex concerns. And then, really, along those lines with competing priorities, physicians and other clinicians are being asked to do things that have absolutely nothing to do with the provision of medical care, like being on the phone for hours with health insurance companies, dealing with denials and prior authorizations. And there's all kinds of administrative work and things that, yes, they have something to do with patient care, but that's not, what we went to school for, so to speak. And so there are just a lot of competing priorities that capture the time of clinicians. And so again, that can prevent them from or cause them to gaslight or to dismiss patients. There sometimes it's a lack of information and knowledge. And so there's this saying that we're taught. I hope they're not still saying this to medical students, but they probably are. But I can tell you, I was taught, back in the 90s, the 1990s, we were taught this thing about if it basically if you hear hoofbeats, think horses, not zebras. And so anytime, medical students have a lot more time on their hands than attending physicians. And so it would not be uncommon for an eager medical student to really go and read about the particular patient and to maybe come up with some differential diagnoses that might not be like the common things. And the supervising attending physician would say, when you hear hoofbeats, think horses, not zebras. And really the idea around that is common things are common. And so the problem with that is that sometimes patients present with common presentations of uncommon diseases or uncommon presentations of common diseases. And so we are kind of it's ingrained in our medical training to think in the box and to think about algorithms. And again, there's a need for that because you do need to be able to fairly quickly have a mental model of what's in front of you or the patient that's in front of you. But when you have a patient that presents with something that doesn't immediately fit into your knowledge base, then there's a tendency, instead of thinking to yourself, wow, I may not have learned this, or I may have forgotten this, or maybe this is outside of my knowledge. The tendency is, well, this doesn't fit with what I know to be this condition. So therefore, you don't have this condition. And so that can also lead to gaslighting. And then one of the other things that we see, and this is why certain populations, and hopefully we'll talk about that, Melinda, are more at risk, is implicit bias. And so we know that there are certain populations of our clients who are more likely to be subject to gaslighting. Women, for sure. There's lots and lots of data about that. People of color, there's lots of data about that. Members of the LGBTQIA plus community, those with disabilities, those who are aging or older individuals, those with underlying mental health conditions, those with obesity. So those individuals are facing implicit bias of the provider, sometimes explicit bias too. But the problem with implicit bias is that it's implicit, it's unconscious. So these are the ideas, the thoughts, the beliefs that we all carry. Literally, everybody on this call right now, we all have implicit bias, whether we like it or not, whether we want to admit it or not. And so we all have internalized certain stereotypes about individuals and groups of individuals, and unknowingly we bring that into the exam room. And even as advocates, we may unknowingly bring those biases into our interactions with clients. And so those implicit biases absolutely can also play a role in the physician or the clinician's tendency to gaslight.
Absolutely. And this calls to really the importance of communication and how much could be saved if people just ask a couple more questions. And you and I were talking in our previous meeting about how communication becomes, prevention, and you can get diagnoses faster if you're just asking these questions. But if there is that implicit bias, if there is that bias, so we're not asking those questions. So you mentioned a couple of groups, but what are some of those groups, if you can go into more detail about what groups we're seeing this more prevalent in and why those groups? Do you have any idea of why we're seeing it happening occurring more often with those groups?
Yeah, well, I guess if we start with people who identify as female or women, I mean, this goes back historically, for centuries, and it kind of is the root of this idea of hysteria that, many of you are probably familiar with, where women, it was not uncommon for women to be literally labeled as being hysterical. And so every medical complaint had some root in psychology or in their psychological health. And unfortunately, that continues. And the sad thing is that I've spoken to a lot of women who have been gaslit by female providers. And so we might think, oh, well, only male doctors or only male healthcare providers are doing this to women. But again, it's because of all of the things that I've mentioned that even as a woman, you may be subject to gaslighting a patient. And so, I think a lot of that just has to do with honestly a patriarchal society that we live in and just cultural norms that while we've all made significant advancements, certainly in 2025, we have not gotten rid of some of those underlying biases and some of those underlying constructs. And the same thing really applies to if we talk about minoritized individuals, people of color. These are just groups who, for many reasons, have historically been oppressed both in the healthcare system and outside of the healthcare system. And there are some really strong beliefs and stereotypes that persist despite us all having many examples contrary to what some of those beliefs are. Also, a lot of times these are individuals who, in general, may have less access to power, less access to control, and so they really are subject to some of the same things in the healthcare system that they're subject to in the world as a whole. I think with regard to those with underlying psychological conditions or underlying physical conditions, again, I think it almost serves as like a shortcut. It's like a mental shortcut that I think some physicians and healthcare providers take. If they can blame it on something that they know, then it's easier. If they can make it fit again into that box, if they know this person has depression and anxiety, they're coming with recurrent headaches. Well, I can blame this on your depression and your anxiety. And it's not that that may not be true. Depression and anxiety can have headaches as a symptom, but this idea of kind of taking this shortcut and assuming without doing a thorough physical exam, without doing a proper medical workup, just kind of blaming these symptoms on a condition that they have can be significantly detrimental.
You hinted at this, that it can happen that both female providers and male providers, but Tracy had a great question. Um, who tends to medically gaslight more, men or women? Do we know?
If we do know, I don't know the answer to that. It's, the one of the problems with this topic is that most of what we know is in the form of surveys and lay literature. There are a few studies, so to speak, but it's very under researched. Probably not surprising to many of us on this call. And so I would say this is an area that is ripe for research and additional information. So I don't know if there's exact data with regard to male versus female or, race or ethnicity. But it's definitely clear that the victims, those who are subjected, have those identities that we talked about. But that's a great question. And if there's anyone here that knows the answer to that definitively, please drop it in the chat.
Yeah. But as you said, a lot of this is going to be subject to people recognizing that this is what's even happening. So if they got a survey that says,
Yeah.
tell about a time that you were medically gaslit, they'd have to have that understanding of what that is in that context to even say, yes, I think this happened. So that
Exactly.
be a problem with, all the survey data, but good to know. So we talked about what it is and why it's happening and who it's happening to, but what's the impact? So what if this happens? Now, I'm being flippant on purpose because it's really does have a big impact, but what are some of the impacts this has for the patient?
Well, certainly, we want to center the patients first in this conversation. And as you all can imagine, it has significant impact on the patient. One, it has an impact on their psychological and emotional health. Whether they even recognize it as gaslighting or not, having the experience of having a medical concern that is large enough, for lack of a better word, that you are even seeking medical care. Maybe this is something that has kept you up late at night. Maybe this is something that has you really worried. Maybe you're concerned about some terminal condition that a family member has, and now you're having similar symptoms. And to present to a doctor's office, a medical office, only to be dismissed has significant consequences. One, they may actually believe, oh, maybe it is in my own head. And so now you have a patient who is no longer trusting themselves. You have a patient who, when that symptom recurs or if the symptom worsens, they are thinking back to, well, that very smart doctor who went to medical school for 4 years and did a 4 or 5 year residency and a fellowship, they obviously know more than me. So this thing is worse, but they told me it was fine, or they told me I just need to lose weight, or they told me I just need to sleep more. And so they are potentially going to ignore their own symptoms moving forward and the progression of their symptoms. So this can lead to confusion on with the patient, feeling lost, stress, self-doubt. It can exacerbate or even cause anxiety or depression. And then it can also significantly impact care-seeking behaviors. And I've seen this with both of my daughters. My daughters are 24 and 29, and their mom is a doctor. So they literally grew up in a household with a physician, where normal care seeking behaviors and things like that have been normalized. But I can tell you, and hopefully they wouldn't mind me saying this, both of them have had experiences where they have chosen not to go to the doctor, sometimes despite my urging, because they have experienced being dismissed in healthcare settings, and they walk away feeling like, what's the point? And so when we impact patients in that way, we not only impact their psychological health, but now we're impacting their medical health. Because when you delay care, we know what happens. By the time you do present, that problem that you had that might have been a small problem is now a bigger problem. So that can cause significant health issues. And then we're breeding mistrust. And certainly, we have learned a lot more about medical mistrust during the COVID pandemic and with COVID vaccination. And I think, that just kind of highlighted what many of us already knew. But this idea of patients not trusting doctors, not trusting healthcare providers, not trusting hospitals, so that when we have medical emergencies like pandemics, or even if we're just talking one-on-one in an exam room, we are creating an environment where patients don't trust us. They don't trust the information that we share. And we're certainly in an environment now, particularly among younger individuals, where they may be more likely to get their medical information off of TikTok than, from the doctor's office. And I say that without disparaging them, because we can't really blame them for seeing social media and the internet as a safer space when they've encountered some of these behaviors that we've been talking about. There are costs to the healthcare system itself. And so we talk a lot about waste in the healthcare system and the billions with a B dollars that we lose to health disparities, health inequities, patient safety issues, medical errors. All of these things have a significant root cause of faulty communication, and gaslighting is part of that. And so when you have a patient who is now presenting for care at a more advanced stage of their illness, that's going to cause cost more healthcare dollars. That's going to take up more healthcare resources. And so, there are significant financial impacts to the system, but also financial impacts to the patient, because again, they're going to potentially require more visits or more interventions, things that might be more costly for them. So, we really cannot underestimate or underappreciate the cost, both psychological, emotional, medical, and financial.
All really, really big impacts. And especially pointing to the fact that not only does it start to make us not trust maybe the provider, but I think it also makes us not trust our own understanding of our own bodies. Like if I am going to listen to the provider and I'm constantly saying, "Oh, well, no, they said this, it's fine," then I stop listening to our own bodies, and we know that our bodies scream at us of what things are. So then we wait, and as you mentioned, just not going and getting the care and pushing it off until we're in a world of trouble. Another question came up that actually goes back just a little bit, but I think it's really great. Judy asks, so how often do age gaps between physicians and their patients come into play? For example, a patient is 80 and the doctor's 35. What do you know about gaslighting with these age gaps?
Yeah, I think we can, again, the data is not super clear on some of the statistics, but I think it's safe to assume that having an age gap is going to impact gaslighting, just like having, anytime there's not concordance, whether it's age, whether it's gender, whether it's sexual orientation, socioeconomic status, race, ethnicity. All of these things can sometimes come into play because of the things we talked about with regard to bias and just not sharing a lived experience. It doesn't mean that if you don't look like me, you can't take good care of me. But, you need to be, all of us need to be really aware of these challenges and aware of our own biases. And so I can certainly imagine that if the patient is much older than the physician or the clinician, or much younger than the healthcare provider, that there can be some challenges with communication, some of which may be generational or cultural, and also that those providers might bring in assumptions, biases that could absolutely impact the care that they deliver. It's a great question.
Yeah. Um, I don't know if you know anything about polypharmacy, but Michael asks, how does polypharmacy create symptoms that might also be gaslit?
Oh, how does it create? Well, polypharmacy, that's a very important topic. And my dad didn't experience, I experienced it through my late father. One of the things that I noticed when I was helping to care for him was this idea of polypharmacy. And he himself was having a lot of kind of vague symptoms, things like dizziness, the kind of thing where you can't really, there's not like a workup for dizziness. And, they may do a CAT scan, it's like, oh, your brain looks normal, and then nobody can figure out why you're dizzy. And so certainly, now that I appreciate the question because it's making me think back, like my dad was gaslit, because there were so many times where, headaches or like dizziness, or he was just feeling weak. Ultimately, one day I just had him go pull all of his prescription bottles. Like I was like, Dad, go get every single prescription that you're taking right now and bring it to me in the kitchen. And I was overwhelmed when he was just lining up all of these bottles and multiple medications for his high blood pressure, which explained why he was dizzy and why he was falling and why he was lightheaded. So I can absolutely imagine that polypharmacy can contribute to this as well. And unfortunately, the gaslighting can happen because, again, we go back to some of the things that set us up or set the patients up. If the physician doesn't have an appropriate amount of time to really inquire, like in my dad's case, his doctors weren't even really asking. And even though there were systems in place that should have prevented duplication of medications and things like that. We know that those systems are not perfect. And so if they don't have the time or they're not taking the time in the appointment to really uncover, are you taking new medications? Have you increased it? Did your cardiologist change anything when you went 4 weeks ago? Then we can see how if a patient has kind of a vague complaint, they're not taking the time to really investigate it, which might be polypharmacy. And so they're chalking it up to something else or dismissing it altogether.
It's so funny when questions trigger stories like that. And you're like, oh, wait, that actually happened. And before I jumped in with that question, I should have had you clarify. Can you explain for in case people don't know, what is polypharmacy?
Yeah, polypharmacy is essentially overprescribing, prescribing multiple medications for typically for the same problem. Because if you have five different conditions, then of course you're going to need five plus medications for those different conditions. But it's really the idea of overprescribing. It's something that we see a lot in the elderly or aging population. There's an idea of deprescribing that doesn't happen often enough. And so maybe at one point, like in my father's case, there was a time when maybe he did need four medications to control his blood pressure. And then maybe he made some lifestyle modifications or lost a little bit of weight, but nobody, thought, oh, maybe now you don't need these four or five medications. So we miss a lot of opportunities to deprescribe. Also, sometimes as patients get older, things that, were super important, just they're not as important to their overall health. And so there are things that could be and should be pulled off or deprescribed. So people end up on just a lot of medications, which tend to have side effects. A lot of times there are medication interactions, and it can lead to some very significant health problems.
Could could providers use the fact that they're on some medication as the gaslighting for the symptoms and just brush it off and say, oh, well, that's because you're on this and not even look at the fact that this is a new symptom?
Absolutely. And, it's hard because, I mean, I'm glad that I think your question, Melinda, really highlights the complexity of the situation. And it kind of takes us back to the idea that often with medical gaslighting, it's unintentional because medications do have side effects. And so, again, going back to that zebra versus horse analogy that I shared, if you have a patient in front of you as a physician or a healthcare provider, and they are complaining of a symptom, and you look at their medication list, and one of the medications or two of the medications that they're taking has that side effect, it's not unusual for you to think. In fact, you should be thinking, oh, maybe you're having this symptom because of this medication. And so the fact that that's your first thought, that in and of itself, I would say is not medical gaslighting. I think that's being an appropriate clinician. However, the next step would be to maybe make an adjustment to the dose of that medication, or maybe to replace that medication and then follow up. And then if the symptom went away, great. Okay, you appropriately attributed that symptom to their medication. Everybody's great. But if you've adjusted that medication or eliminated that medication and the patient is still having those side effects, then it warrants, further investigation. And I think this is where we start to get into trouble, is like um a lack of commitment to really investigating the problem and a desire to kind of find the quick, easy answer, which may or may not be the right answer. And ultimately, it comes down to listening to the patient, where you talked about communication, Melissa, because a lot of times the patient will have an idea. A lot of times we know our bodies, our family members, our clients know their bodies. And a lot of times the patient may have already come to a preliminary conclusion about what they think is wrong. And if they mention that in the doctor's office, again, a form of gaslighting is to immediately be dismissed. Or some of you may have heard, patients are, oh, you went to Dr. Google, like if they say, hey, I've been having these five symptoms, or I've been having these three symptoms, and I did look this up, and I saw that this particular condition presents this way. Sometimes the snarky doctor or clinician's response is, oh, you stay off of Google, stay off of Dr. Google. Or sometimes they may be even more disparaging, again, depending on whether egos have been bruised, or if they've had a rough day, or if they have 20 patients waiting for them, or if they just got cursed out by the patient that was waiting for them, All of these things come into play. And at the end of the day, again, not to make excuses, but physicians are human, nurse practitioners, physician assistants, we're all human. And so we're carrying the stresses of practicing in this broken environment, personal stressors, things, relationship issues, issues with our children. We're bringing all of that into the exam room. And unfortunately, all of those things can contribute to gaslighting a patient.
So when this happens, because there's all these factors that can come into play, what do we do? What can we do about this? What maybe let's break this into two. So for advocates, what can they do? What advice would you have for providers? And then, for patients and family members, what do we do? Do we have tips for these different categories that you could share?
Yeah, I think the first step, like everything else, is awareness. So again, thank you all for inviting me to talk about this because if we don't know what gaslighting is and what it looks like, then as advocates, we're not going to be able to effectively support our clients. So awareness is the first step. So we're doing that today. And I like acronyms. And so for advocates, the acronym that I use is HEAL. And the H is for here. And so certainly we've just talked about how and oftentimes our clients are not being heard, they're not being listened to. And so certainly we need to be the ones to listen to our clients, to hear the concerns that they have, to validate their concerns. And then the E is for educate. And so we need to or educate and empower. So we need to educate our clients, now that we see how these present, if you are engaged with a client and they're talking to you about these types of encounters with their physician, with their healthcare provider, then we need to educate them. Hey, you know what? That sounds like possible gaslighting. And then we need to empower them to respectfully, stand up to their provider, to maybe schedule a follow-up visit, to maybe send them a message on the patient portal, but to not allow their concerns to be dismissed. The A, of course, is to advocate. And so, we can either give our clients the tools to advocate for themselves, or we can be that advocate. We can be the one to intervene and maybe to request a conversation with the healthcare provider or send an email or maybe accompany them to that next visit so that we can be that neutral party to maybe bring up that gaslighting to the provider. And then the L is for link, and that's to provide our patients to resources, whether that be support groups, whether that be legal resources. Unfortunately, there may be situations where there may be legal actions that need to be taken. Mental health professionals are important because patients who have been subjected to medical gaslighting, as we talked about, can either have an exacerbation of their underlying mental health conditions or it can actually cause mental health conditions. And so making sure that we are able to provide resources to them for their psychological health and well-being. For the healthcare providers, the acronym that I use is CLEAR, and the C is for curious. And that's just, curiosity is a great approach for all of us. And despite all of the systemic barriers that I shared, I think it's imperative for healthcare professionals to approach every patient with a genuine sense of curiosity and a desire to learn. So instead of going in, we get the chart these days, it's electronic. You see the chief complaint. I can tell you that sometimes, depending on what that complaint is, there is a natural, like, you're like, oh, and that's just the truth. There are certain complaints that just evoke emotion. You already know that it's going to require, a lot of unwrapping, unpacking, and that's wrong. Like that is not right. It's a natural reaction, but it's wrong. And so to approach every patient with a genuine sense of curiosity, to practice cultural competency is important. The L is for listen. We've talked about the importance of listening to patients. So healthcare providers need to take the time, make the time to listen. The E is for empathy. Even if you think that the patient is wrong, even if they have been on Google and whatever condition they're telling you they think they have, or you think that that's not it, to really practice empathy in your dialogue and in your conversations with patients so that they're not left feeling disparaged. And there are ways to express that in a way that leaves them saying, you're going to encourage or you're going to basically like affirm, I'm glad that you care about your health. Like, thank you for looking that up. That shows that you're a responsible patient, as opposed to accusing them of going to Dr. Google. And then saying, this is why I don't think that is what you have. Which takes me to the A, which is to acknowledge. We need to acknowledge gaslighting as a reality. We need to acknowledge our biases and interrupt our biases. And the R is for reasoning. And this was something I had several people who have been subject to this. They were kind enough to be on the phone with me. This was a couple of years ago for like an hour each and share their painful story. And one of them talked about this reasoning and the idea that healthcare providers need to just explain their reasoning behind why they're dismissing a complaint. Because maybe it's not gaslighting, but if you're telling me, Nicole, I hear you. I can only imagine how disturbing this is for you. And I know that you think that you have a brain tumor, but let me explain to you why I don't think this is a brain tumor. If this were a brain tumor, you would likely have this, this, and this. Or when I examined you, remember when I did this thing in your exam and I had you do this, I had you walk, I had you put your finger to your nose. Those are things that I was doing to rule out a tumor. So those are things that, again, because of time, most healthcare professionals are really not explaining all of the dots that we're connecting in our brains, but taking the time to explain your reasoning to the patient so that they know that they were not dismissed, but you were doing all these mental gymnastics in your head that they were not privy to. And so there was a method behind this conclusion that, they don't have this life-threatening condition. And then lastly, for patients, I and clients, I always use the GPS system, which is a play on your GPS doc, which is the name of my advocacy company. But the G is to gather information, and that really just has to do with asking questions. Patients can never ask too many questions, regardless of whether they're being dismissed or ignored or the physician seems annoyed. But this idea that we learn by asking questions. And so making sure that they are asking questions, making sure that they are prepared with a list of questions, that they've, put some time and effort into the visit ahead of time. The P is to position yourself as an expert. So if you are a patient or family member listening or watching, understanding that you are the expert. It doesn't matter how many years I went to medical school. It doesn't matter my residency, the books I've read, like none of that matters because I'm not in your body. And so you know your body and you are the expert for your body. If you're a caregiver, you are the expert for that person. My two older sisters and I, when we were caring for our dad, we could pick up very, very subtle changes in my dad's personality long before a CBC or an electrolyte panel was going to be abnormal. And so the patients and caregivers need to position themselves as the expert. And then the S is to speak up. We've all had situations with ourselves, with our family members, and with our clients where the gut instinct was correct, but they suppressed it because a healthcare provider maybe gaslit them or just told them like, no, I don't think it's that. Or they were dismissed. And so they thought to themselves, like we talked about earlier, well, they have more knowledge, more experience than I do. Maybe I'm wrong. So patients and our clients, they need to be empowered to speak up, to share the concerns that they have, and to escalate concerns if they're not being properly addressed.
Those are phenomenal. I hope everyone else was taking notes because I wrote them all down. I'm going to be keeping those in my repertoire. Um, James asks, so if gaslighting has already happened, and it has happened over an extended period of time, what can they do and how could they possibly speak up retroactively? Because I think I immediately start going into trauma-informed care because I think this could be quite traumatic. And if I've spoken up enough times and I've gotten shut down, I'm gonna have that response to, well, now I'm gonna shut up. I'm not gonna ask any questions. I'm gonna not speak up. So immediately I start going into how could I help with using trauma-informed care techniques. But what advice do you have for somebody who's been going through this or is currently realizing I've been going through this? What do they do? How do they learn to speak up?
Yeah, I want to say before we talk about speaking up that as a physician and a professional healthcare advocate, I am a huge advocate of firing doctors. So sometimes your doctor just needs to be fired, period. Like if you have a healthcare professional who has repeatedly gaslit you, then it really may be time to find another provider. If you are otherwise really connected to this healthcare provider, or sometimes we are in situations where you can't, maybe they are the world's expert on the rare condition that you have, and you don't have the luxury, or maybe they're the only one that takes your insurance, in your geographic area. So certainly if you are in a position where you can't find someone else, the way that I would start is to really engage in a respectful conversation where you are truly expressing how you've been made to feel, as opposed to you do this, So it's always best, even I mean, this isn't a romantic relationships talk, but it's some of the same practices that, marriage counselors and other relationship therapists recommend, which is centering your own feelings so that the other person isn't placed on the defensive. I think it's very hard to have these types of conversations in the context of a regularly scheduled medical visit. And so, one thing might be to request, like, can we have I have some concerns. I would like to schedule an appointment with you specifically to discuss my concerns, because it's going to be really hard for you to interject this topic in the context of, a blood pressure check or whatever, or a new patient visit. So, but then in terms of just some tactical things, I think really looking at the healthcare provider and saying, if it's long term, I have been thinking about my encounters with you, and I have some concerns. I know that you're a great doctor, and I appreciate the care that you've provided me. And I am realizing that there are concerns that I've expressed to you multiple times, and I don't feel like you have heard me. I don't feel that you have addressed my concerns, and then just kind of pausing. And they're probably going to be shocked because they're probably not used to patients saying those things to them, but hopefully they will take a few minutes or seconds to reflect. And then hopefully you can really begin to engage in a dialogue. I think these are conversations that could really be facilitated by us, by health advocates, because we could be that neutral third party. We're not really neutral, but we could be that third party to advocate for our clients, and it might be less awkward for both the healthcare provider and for the patient, our client, if we're the one that is able to initiate that conversation.
I know that is a role I have had to take in a few cases with the clients that I've worked with, is they've had that distrust built. They felt like they were getting shut down. They're like, I don't know how to do this. So that's one of the things, in my practices, is a difficult conversation navigator. That is something that an advocate can do, whether it's
Mhm.
one-on-one and helping you practice that. That's something I do sometimes is, okay, I'll be the provider, you practice this with me. And if they
I
don't
love that.
have that confidence, then I will go into that doctor's appointment with them and say, wait, 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 maybe you didn't intend to say it that way, but this comes off. Can we explain what is happening here, why you're asking that? Um, Tracy asks, can someone ask the doctor what their differential diagnosis for symptoms for can they ask about that? Is that an acceptable question?
Yes. Absolutely. And if you use the word differential diagnosis, then they're gonna, it might catch them off guard. But yeah, you could use that term, or you could simply say, let's say you go with the complaint and you're being gaslit, and the doctor is saying, "Oh, I think you just need to lose a few pounds or whatever." Then you could say, and this is a great way to directly address and combat medical gaslighting, and perhaps even bring it to the physician's attention. You could say, okay, I understand you think it's because of my weight. What are some other things that could be causing this? Or what are some other medical conditions that might present this way? That is going to be something that one will pause the healthcare provider. And there's nothing more beautiful than creating a pause in a medical encounter, because it gives that doctor, that physician who is go, 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 go. Again, they're thinking about all those things that we've already talked about. That forces them, hopefully, to just like take a breath and pause in the moment. So that is a wonderful question to ask. It also helps you to get a sneak peek into their brain, that reasoning part of the clear acronym, and hopefully they will be open to sharing. I've had, as a pediatrician, I've had moms ask me that question, and in at least one circumstance, it led to the patient's diagnosis just by the parents saying, what else could this be? Or what are the things that are you worry about when you see someone with this problem? So I think that's a wonderful way, and I would encourage all of us to implement that.
And I think in part, it sounds like this is a lot more assertive a way to present that question to your doctor. And as you said, you are the expert. And I think one of the things, just from a communication standpoint, if we go into that appointment and we're like, well, I looked on Google, that's going to shift the conversation one way. But if you say, I've done some research, and you just say, with these symptoms, could it be this? What are frame it in a way where I'm saying, here's what I think. What are the alternatives that this could be? It sets it up as you are a bit more confident in what you're saying, and that might help prevent, hopefully it prevents that gaslighting, because they're going to see that you do have this knowledge, you are doing some deep thinking about this, and it's not just, oh, I went to Google.
Yes.
So it might be a piece of advice. Kathy asks, any tips to gather the succinct information to provide to a second or third opinion for a medical issue? So how do we hold back from flooding the new doctor with this whole narrative of everything that happened
Yeah.
and give them just what they need so we can take the best advantage of that 9 minutes that we're given?
That's a great question. If a really good physician or healthcare provider is going to not have a problem with you seeking a second opinion, and the best physician or healthcare provider will actually help you. And I say that because you can employ that first opinion doctor, you're the primary doctor or the specialist. You can employ them to help you gather that information because as a physician or a clinician, they're going to know what that other colleague wants to know. Like they'll be able to concisely do that for you. I recognize that that is not always the situation. And I also recognize that many patients and family members automatically assume that they're going to offend the first doctor if they want a second opinion. But again, that should not be the case. So I would say consider just, going to the original person. But also, I think that's certainly where those of us who are professional health advocates who have a medical background, whether it's nursing or, physicians, I think that PAs and Ps, I think that's where we play a very important role because we've been in those clinical settings ourselves. And so we're going to be able to really distill down what the pertinent information is. If the person is not working with an advocate, they could also start with their patient portal and their problem list. Hopefully, if it's been done properly and it's up to date and things that are no longer active are off of that, sometimes that can be a place to start where you're seeing a concise list of your active medical problems. And then with each of those medical problems, a short blurb about maybe the latest diagnostic studies that were done, or when was this diagnosed? What are your latest lab results related to that particular diagnosis? Because you're right, it can be very overwhelming for even an established for any doctor when a patient comes in or a family member comes in with a binder. These again, I'm just being honest. These are cues that again they're very appropriate because if you have a binder, that likely means you've been around the block a few times and you have a either a significant condition or multiple conditions. And to the clinician, that is often it evokes this kind of like anxiety, and it's like, oh my gosh. I'm not saying don't bring your binder, please bring the binder. But this idea of really trying to be as concise as possible so that they can provide the best service for you.
Thank you for that. As I do want to be mindful of everyone's time, any last words, any last advice?
I think, my main advice is what I want to say before I give advice is it's likely that many of you on this call, just based on the statistics, have experienced medical gaslighting. So on behalf of physicians and other clinicians, I want to say I'm sorry because it really is like a very, very difficult thing to undergo. So that let me say that first. And then in terms of advice, I would say just trust your gut. I mean, that's probably the most important thing that I can say. Our instincts and we say gut, but like these are biological mechanisms that we have in our bodies that are literally built for us to recognize danger. And so if you're feeling a certain way, if you're having that little voice in your head or your stomach's cramping up, those are likely valid reactions. And so trust your gut, trust your instinct. Bring people with you to appointments. If you have to go to a medical appointment, it's always good to have a third party who is listening and watching. That may be the person to let you know that you've been gaslit. And then hopefully this talk has been helpful in terms of giving you some specific tactical things to do if in fact you find yourself in that situation or your client is in that situation.
This has been absolutely fantastic.
Thank
I
you.
do want to, just on behalf of everyone at Health Advocate X, thank you all so much for your time and attention. And thank you so much, Nicole, for this amazing, amazing bit of information. This is, as always with our community conversations, will be posted and shared and is something that you can share with others. So I hope that you will do so because I think this is something that really should be a conversation that lots of people are engaging with. So thank you, everybody.
Thank you, everyone.
There were a couple questions that we didn't get to. I'm so sorry. But I hope that this provided everyone with a lot of great information. So we do these community conversations quite often. So please keep an eye on the events coming in, and we'll see you next time. Thank you again, Dr. Rochester.
You're welcome. Thank you for having me. Bye,
Absolutely.
everyone.